All right, just gonna quick review what we did yesterday, and we're gonna go into a little bit more detail. Once again, treatment of mood disorders, week number 2. Can you guys hear me clearly? Everything good? Once again, any questions with this slide, with the neuron? All right, the important thing that you should understand is that all the magic happens in the soma, right? Because that's where the nucleus is, and that's where all of the second, third, fourth, fifth messengers happen. Phosphorylation happens there as well, and that's where proteins are created. And that those proteins are what's going to create, neurogenesis and new connections to other sites of the brain, right? Again, synaptic neurotransmission. Just remember that most of the monoamines, all the monoamines, dopamine, norepinephrine, serotonin, have to be recycled, and they're recycled through pumps. So we have norepinephrine transport pumps, right, which recycles norepinephrine. We have serotonin transport pumps, which recycle serotonin, and we have dopamine transport pumps. Remember, in the frontal lobe, we do not have dopamine transport pumps, all right? We use norepinephrine transport pumps. The reason why that's important is if you give someone a norepinephrine reuptake inhibitor, you're actually affecting dopamine in the frontal lobe. So if you give someone an SNRI or, I don't know, atomoxetine, which is a norepinephrine reuptake inhibitor, you're actually increasing dopamine using norepinephrine transport systems. All right. So there will be an increase in focus and attention as well. All right. So you can tell patients that we're giving you a medicine that's working on serotonin, norepinephrine, but there could be secondary effects in increasing dopamine as well. So you might have better focus, more energy. Okay. Types of neurotransmission, just remember, anterograde is classical. That goes from presynaptic to postsynaptic. Retrograde is when the postsynaptic neuron communicates backwards and talks back to the presynaptic neuron. All right, so it's a constant back and forth combination. Number 3, once again, volume neurotransmission happens in the frontal lobe, dopamine. Dopamine puffs, right, because you don't have a lot of dopamine transport systems in that area of your brain. So, it has to compete with norepinephrine. So a lot of dopamine still stays there persistently. Okay, that's important because you need a little bit of dopamine tone. So there's something called tonic firing and phasic firing. Did you guys read that in the style book? You know what tonic and phasic means? Anyone want to try to explain it to me, what the difference is? What is tonic dopamine firing? Okay. Tonic dopamine firing means there's a constant tone. Think of like a metronome. Boop, 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 right? It's constant. It's keeping you focused. It's keeping you engaged. It's keeping you alert, right? Phasic firing happens when you like something or something catches your attention, right? Sometimes we call that salience, SALIENCE. Salience means that something catches your attention, so you might get if it's pleasurable, you're going to get a burst of dopamine, right? And that phasic firing is good because that's how you learn as well, right? If I say something that you find interesting, your dopamine neuron is going to be firing phasically. And the phasic firing eventually is going to help form memories and new connections, all right? The problem with too much phasic firing, when you're using phasic firing too much, especially in the mesolimbic area, is that you can cause addiction, right? Addiction and dependence. That's what happens when people use stimulants or cocaine. Too much phasic firing, or you give them Adderall IR and they're using more than they should. You get that euphoric effect. Too much phasic firing, too much reinforcement, right? And then they get dependent on it, right? And that's kind of like the blueprint for addiction. Any questions with that? So tonic is constant all the time. You need that for attention alertness. Phasic firing is for memory, attention, focus.
Professor, can you say what area of the brain that happens in again? With the
Phasic firing usually happens, well, when it comes to pleasure, that would be your mesolimbic area, right? That's the ventral tegmental area, innervating the nucleus accumbens or the ventral striatum, right? That's for pleasure. Too much phasic firing that's persistent can actually cause psychosis. That's why people who take like cocaine or amphetamines, they're getting a big rush of dopamine that's constant, keeps innervating that postsynaptic neuron, right? So that will cause psychosis or increase the risk of psychosis or mania, right? So it happens in numerous parts of the brain, but just understand that maybe in the frontal cortex, that would be more focus, memory, attention, phasic firing when something catches your attention. When it comes to pleasure and addiction, it would be in the mesolimbic area, all right? Once again, important concept because this is going to follow you through your whole career and understand how medications work. Upregulation, when you're blocking the receptors are going to compensate by upregulating because you're blocking it for too long or becoming more sensitive. So upregulation usually accompanies sensitization, right? Downregulation usually follows desensitization. Both things will happen. The receptors won't be as sensitive and they're going to reduce in the amount. Remember, that's what happens when people develop tolerance to medication. You give them a certain dose of meds, right? it's innervating that receptor. Let's say you're using GABA, you're using a benzodiazepine, like Xanax, for instance, right? It's hitting that GABA receptor. You take too much Xanax, after a while, it's going to start to what? Downregulate, right? It's getting hit too much and becomes desensitized. So you're going to need more. You're actually going to need more of the medication to get that same effect because you're not going to have enough receptors. Agonist spectrum. Agonist mimics the regular neurotransmitter in your brain, whatever that is, serotonin, dopamine, or epinephrine. Partial agonist is a stabilizer, right? If there's too much activity at that part of the brain, you give them a partial agonist, what's going to happen? It's going to work as a net antagonist, right? If someone has schizophrenia or someone has mania, you give them a D2 partial agonist like aripiprazole, it's going to cut off that dopamine secretion a little bit. So it's going to minimize it, right? If there's not enough, it's going to work as a net agonist. So it's going to give you just enough. Say, for instance, someone has negative symptoms or poor focus from their depression, and you give a little bit of a D2 partial agonist, and say they're on Zoloft, right? Sertraline, SSRI. And they say, my depression is a little better, but I still can't focus. I'm forgetful. Okay, let's add a little bit of partial agonist. And when they ask why do you want to add that? I'm going to explain to them, well, what a partial agonist does is in your frontal lobe, you might not have enough dopamine, right? That dopamine is there. You need that for attention, for focus, and concentration. So I'm adding a D2 partial agonist because my belief is that there's not enough dopamine innervation in that part of your brain. The D2 partial agonist is going to increase dopamine just enough in which you're going to have more focus and better attention, right? Does that make sense? An antagonist, there's too much, you're going to block it, right? We use that when patients are psychotic, right? Obviously in the mesolimbic area, too much stimulation of dopamine in the mesolimbic area, you can give them a D2 antagonist, right? It could be Haldol, risperidone. Any antipsychotic usually is a D2 antagonist. You're going to block those receptors and it's going to, it's going to negate the effect of dopamine and psychosis should go away, or the delusions, whatever it is, right? If someone is aggressive, it's going to do the same thing. If it's psychotic aggression and they're paranoid, you're going to give them a D2 antagonist in the mesolimbic area. Or if they have psychomotor agitation, let's say sometimes patients might come to the hospital and they're in the ER and they're not psychotic, but they're tearing up the place, right? They're just very angry. What does the doctor usually order, right? Give them Haldol. Why? Not for the psychosis, but to dampen down that psychomotor agitation, which might be in the nigrostriatal area, right? Or a little bit in the mesolimbic also. Not enough for psychosis, but enough to kind of get them angry. And it's going to dull that down by blocking it, and it's going to cause them to calm down, right? Once again, inverse agonists, we don't have too many of them in psychiatry, but just for your information, we have clozapine. It's actually a histamine inverse agonist. So at the histamine receptor, it's an inverse agonist, all right? Not really clinically significant at this point, but just if someone asks you, you would know that answer, right? Pharmacokinetics versus pharmacodynamics. All right. Once again, absorption, how are you taking the medication? Usually it's PO, or if you take it by PO, bioavailability is much less, right? If you take it by IV, you get that full absorption, 100% bioavailability. So usually they'll give you less, right? Distribution, depending on the fat content, water distribution, medication might go. Talking about distribution, Depakote, we're going to touch on that a little bit more of that later on, is actually it's very highly protein bound, right? So what does that mean? If a medication is highly protein bound, how can that affect your patients when you're giving the medication to them? Anyone want to try to explain to me how that's significant?
So like if there's like another medication, like say they're taking like Coumadin, which is highly protein bound, won't it affect it?
It could be, yeah, that too. Yeah. Just to make it simple, let's say, for instance, I have someone on Depakote and they're homeless, right? And they're not always eating appropriately. So obviously their albumin levels are going to drop down, okay? The problem with that is if someone has hypoalbuminuria, right, their Depakote levels are going to spike up because in reality, when you do a Depakote level, it's doing the total Depakote level, right? So if someone has hypoalbuminuria, usually I would actually order a free Depakote level because that's going to give me the Depakote level that's free because whatever is free is what actually can make it to the CNS, all right? So the issue with that is if someone's not getting adequate nutrition, I would explain to them that, if it's outside their head, obviously they're homeless and they can't, I would probably switch their medication because it's dangerous because, Depakote has a lot of hepatotoxicity. It can cause elevated ammonia levels, which can, cause them to be confused. So just know that Depakote, right? So what's the normal level for Depakote? Anyone know? What's the normal Depakote levels? Okay, I'm going to give you a tip right now to remember all the levels for lithium, Depakote, and carbamazepine. All right, half a dozen to a dozen. Just remember that, half a dozen to a dozen. So half a dozen is what, 6? A dozen is 12. Lithium, 0.6, half a dozen, 1.2. All right. Carbamazepine, 6 to 12. Depakote, 60 to 120. Does that make sense? Look, the levels are always going to change depending on the lab, but on average, if there's a test question, it's going to be close to those numbers. All right. So on average, normal lithium level is 0.6 to 1.2. All right. There's some labs that say 0.8 to 1.3, but again, it's around that number, right? 0.6 to 1.2. Depakote, usually 50 to 120. I've even seen 80 to 120, but around that, half a dozen to a dozen. All right. Carbamazepine, some labs have 0.8 to 12. 8 to 12. Some labs have 6 to 12, but still half a dozen to a dozen. Does that make sense? All right. 0.6 to 1.2 for lithium, 6 to 12 for carbamazepine, 80 to 60 to 120 for Depakote. All right. Good way to remember things. CYP drug interactions. If you give someone an inhibitor of a CYP enzyme, right, all the substrates that need that CYP enzyme levels are going to go up, right? Because you're inhibiting it. Can't be broken down. You give someone an inducer, you're going to create more CYP enzymes, so it's going to eat up all those drugs. Anything that's a substrate of that medication is actually going to go up. Okay. Someone who's a rapid metabolizer, that's usually genetic, right? Their body genetically makes more CYP enzymes than needed. Some people are just rapid metabolizers. You even have ultra rapid metabolizers, and you have slow metabolizers. Usually when you do pharmacogenetic testing, normal is called intermediate. So you'll see that sometimes. IM, intermediate metabolizer. That's someone that has just the normal amount of CYP enzymes. If someone's a slow metabolizer, they don't have enough, right? Someone's a rapid metabolizer, they have a lot. Ultra rapid means they really have a lot. Like you're gonna give them the medicine and the body's just gonna eat it up. You might as well just switch to something else. Okay.
Professor, quick question.
Yes.
With the inhibitor and inducer, so like if you're taking an inhibitor of a drug, will that mean there's more free drug? Is that what you mean?
When you give someone an inhibitor of a drug, there's two steps to it. So
Yeah.
if you have an inhibitor, think of how many CYP enzymes are going to be there, right?
Okay.
It's inhibiting the CYP enzyme. So that means there's going to be not enough. It's not going to create enough CYP enzymes. So you need the CYP enzymes to break the medications down. So what's going to happen? Then meds are going to go up.
Yeah.
All right. So it's two steps. Because if you don't look at it in two steps, you're going to get confused.
Got it.
Because when you hear inhibitor, you might think, oh, it's inhibiting. Maybe there's less of the medication, but no, it's actually the opposite.
It's more.
Inhibiting the thing that's going to eat up the medication. All right.
Got it. Okay.
Like I said, the good example I like to give like practical examples. So a lot of people do drink chamomile tea. Chamomile tea is a very potent CYP3A4 inhibitor. All right. That has a lot of interactions with benzodiazepines, which are 3A4. All right. Patients who have medical issues, statin drugs are 3A4. All right. 3A4 are some of your antipsychotic medications at 3A4. So someone drinks chamomile tea, those levels are going to go up, right? Quetiapine is a 3A4 substrate. Another common inducer that could be taken is omeprazole. All right. Someone has stomach issues, they go to a primary care doctor and they give them omeprazole. It's going to increase the CYP enzymes, and what's going to happen? Their medication the levels are going to go down. They're going to stop working. All right. Any questions? St. John's wort. All right. Another medication. All right. Actually, that's an inducer. St. John's wort is an inducer of CYP enzymes. So someone wants to take St. John's wort and they're taking, I don't know, antipsychotic medication. All of a sudden, that medicine is not working. If you combine St. John's wort, because it is marketed as an all-natural antidepressant, and they're taking that together with an SSRI, they have a higher risk of developing serotonin syndrome. All right, you guys know that? So if someone's taking St. John's wort and they take an SSRI, they have a higher risk of developing serotonin syndrome. Yes. Someone has a question? I'm sorry, my cursor is not working, so if you can just ask it. Someone wrote something in the chat. Someone's writing something on the chat. What is it? Let's see. Sarani, you can't hear you. All right. Sorry, guys. Hey, what's happening? Give me 1 second. Let me make sure I'm recording. 1 second. All right. So going back to the inducers, right? St. John's wort is an inducer, but when combined with SSRIs, it can cause serotonin syndrome. Do you guys know what the side effects or the effects are of serotonin syndrome? That's important to know. That's an important test question also. What do you normally see? Someone's taking
Confusion, sweating, hypertension, tachycardia.
Okay. What is specific to serotonin syndrome as opposed to neuroleptic malignant syndrome, which can look very similar? Hyperreflexia and clonus, right? Do you know what clonus is? Clonus is a rapid movement. So a good test for clonus is if a patient is laying down, what you do is you dorsiflex their ankle and it's gonna rock like this. It's gonna move. That's called clonus. All right, you move it and it's gonna rock. Hyperreflexia is you know, let's say you do the patellar reflex, you hit the you touch it and it's gonna move very quick. Hyperreflexia. All right. So besides knowing that they're taking an SSRI, then you would assume that they're taking an SSRI. Maybe they combined it with another serotonergic medication that is serotonin syndrome. But sometimes people are on numerous meds and they could have serotonin syndrome and NMS at the same time. But usually NMS, there's really, really bad rigidity. All right, very rigid. Remember, you're blocking dopamine, the muscles get very stiff. Besides the obviously the autonomic issues and the confusion and all the other things. All right. Pharmacodynamics, how does it work in the body, right? What receptor is it blocking? Is it a D2 antagonist? Is it 5-HT2A antagonist, all right? Parts of the brain, just remember that, you know, the neurotransmitters don't work by themselves. They all interact with each other. So sometimes when you give someone a serotonin reuptake inhibitor, it is going to affect norepinephrine indirectly, especially because there are serotonin receptors on norepinephrine neurons, right? They're called heteroreceptors, and there are serotonin receptors on dopamine neurons as well. So they all kind of interact with each other in a certain way. That's what makes psychopharmacology kind of complicated, because you can't just affect one neurotransmitter without affecting another neurotransmitter, right? And if you inadvertently affect a neurotransmitter you don't want to affect, you might have side effects, right? Let's say, for example, you give someone a medication for give them a tricyclic, right? For instance, the dirty drug. So you really want this increased serotonin norepinephrine, but since it has alpha blockade, you're inadvertently giving them orthostatic hypotension. It also has anticholinergic, so now they're not using the bathroom. You give them constipation, right? They have antihistamines, so now they're sedated all the time, and they feel groggy, right? But you really just want the serotonin norepinephrine part of the medication, right? Monoamine hypothesis of depression, once again, means that, you know, that we don't have enough serotonin, norepinephrine, dopamine. I mean, that's a very basic way of looking at it. But there might be some people that have a deficiency and they do respond to our medications well. But most people don't. There's some people that you really need to do a full lifestyle change, all right? You got to go to therapy, you need to change their diet, change their sleep patterns. Sleep is very important. So when people come to you, even if it's just for depression, you want to rule out other things, right? So if someone comes to you for depression, you should rule out bipolar depression as well, all right? That should always be on your rule out. So if someone comes to you with MDD, you should always have a rule out of bipolar depression. And because you never know, mania can come later on. So there's many people that I see, because I see kids and adults, in which they were diagnosed with depression at age 12, and it wasn't until they were age 17 in which they had their first hypomanic or manic episode, all right? So you always have to rule out for that, because the thing is, once they have that mania, hypomania, treatment's going to change. You're not going to keep them on an SSRI because it's going to destabilize them, right? It's not going to work. It's not going to work, or we can cycle them. Makes them rapid cyclers, which is what, 4 or more mood episodes in a year, or it causes them to have mixed features. Mixed features means they have either a full diagnosis of depression with some hypomania or mania, or they have the full diagnosis of mania and mania with a little bit of depression in there. And it's very complicated to treat, because you have to give them a med that treats the symptoms of mania and a medicine that treats symptoms of depression at the same time. And they normally don't have full remittance, right? Partial response, and it's going to take a long time for them to respond to it. Any questions? Malfunctioning brain circuits. There might be a few questions on this. Just understand how the brain works. Nucleus accumbens, right? Reward pathway. When it's innervated too much, it can cause psychosis. When innervated too much, it can cause mania. When you don't have enough dopamine there, there's low motivation, decreased interest, anhedonia. That's a dopamine problem, right? It's a dopamine issue. Once someone tells you, I'm not motivated, I don't feel pleasure, in your mind, you suspect that's a dopamine issue, right? If someone says, I can't get out of bed, I'm really tired, I feel fatigued, well, before you diagnose them with depression, you probably should do a TSH level, right? And you probably should order CBC to make sure they're not anemic, right? So you have to do that. A little bit above the scope of this class, but as you guys start practicing, we'll talk about that when you guys progress, right? What labs to order depending on the diagnosis. On average, I always do a TSH level just to make sure. Okay, striatum, motor pathway, obviously. If there's issues there, you're gonna have psychomotor issues, right? Psychomotor slowing, retardation, or bradykinesia is another way we say it, right? Hypothalamus, sleep and appetite changes, all right? Cerebellum, you guys know that, psychomotor changes, right? They might have ataxia, can't balance, they're falling all over the place. Prefrontal cortex, that could be a norepinephrine and dopamine issue. Once again, I know this was complicated and I tried my best to explain it again yesterday, but the reason why it takes so long for the medications to work, because you have to wait for the down regulation of the autoreceptor, right? Specifically for this one, for the SSRI, on the serotonin neuron, you have receptors called 5-HT1A autoreceptors. Those autoreceptors are the emergency shutoff valves. That's how your brain stops excitotoxicity, because you don't want to keep innervating serotonin over time because excitotoxicity can be damaging to the postsynaptic neuron as well, right? It doesn't get a chance to rest. So what happens is once enough serotonin starts coming out, right, in the absence of depression, obviously, some serotonin is going to move to the back, bind to those autoreceptors, and that's going to turn that serotonin, okay, I'm good, right? Shut down. Just going to shut it off, then it restarts again a little bit later on, okay? So it's not always persistent. When someone has depression, sometimes we believe that there's not enough serotonin. So what happens is actually an upregulation of the postsynaptic serotonin receptors, and there's upregulation of the 5-HT1A autoreceptor, right? I'm gonna say that again. When someone's depressed and your body wants homeostasis and there's not enough serotonin in the cleft, your receptors are gonna accommodate to that, right? So if you don't have enough serotonin, your postsynaptic neuron is actually gonna upregulate, create more serotonin receptors, right? Because it's not getting enough serotonin innervation. And at the same time, those autoreceptors are not getting enough serotonin innervation, so they're going to upregulate as well. So another hypothesis for depression is that there's an upregulated 5-HT1A autoreceptor and upregulated postsynaptic serotonin receptors, right? And apparently they've even done autopsies of patients with depression, and they found that there was an upregulation of those receptors. Not everyone, but there are some patients that have upregulation of those receptors. So that made scientists think maybe that is related to some people's depression, all right? Does that make sense? Is that clear? So it's upregulated. So when you give them an SSRI, what's going to happen? It's going to downregulate and go back to the way it should be, right? HPA axis, just remember, overactivity of cortisol from the HPA axis is going to cause shrinkage of your hippocampus and your frontal lobe. When you have shrinkage of your hippocampus and your frontal lobe, you're going to have worsening of symptoms, all right? The hippocampus kind of helps tell your hypothalamus as well, helps control it and say, look, there's too much cortisol release, shut down. Right? That's due to glucocorticoid receptors on those parts of your brain. That's part of the negative feedback loop. Those glucocorticoid receptors, after a while, when enough cortisol is being leaked into your bloodstream, some of it's going to reach up to your brain, right? And once that cortisol reaches up to your brain, it's going to bind to glucocorticoid receptors and it's going to tell it to shut off, right? But after a while, too much cortisol release is going to desensitize that glucocorticoid receptor, and what? It's going to stop. So you're going to cut the brakes to it. There's no brakes. Cortisol is free to release, excitotoxicity, shrinkage of the hippocampus, shrinkage of the frontal lobe, right? Chronic inflammation, once again, it's due to microglial activation, which causes monocytes and macrophages to permeate through your blood-brain barrier. Once the macrophages and monocytes, they're not supposed to be inside your brain, right? But somehow they get in because stress, inflammation causes microglia to open them up, right? It becomes permeable. Once they go in there, they start eating up parts of your brain, right? So it actually causes cell death, and that reduces neuroplasticity, and therefore you could have symptoms, all right? All right, major depressive disorder. Make sure you know this, just have an idea of it. So make sure it has to be at least 2 weeks, right? So you have to have these symptoms for at least 2 weeks. And you have to have either low mood, right? Or anhedonia. Those are two that have to be there. You have to have at least low mood or anhedonia, all right? In children, you can count irritability. So children can have irritability. They don't have to have low mood, and they can technically get diagnosed with depression, all right? But they have to have the other symptoms as well. Changes in appetite, changes in energy, having guilt, suicidal ideations. Any questions with that? So with kids, instead of low mood or anhedonia, you can use irritability. Medications for major depressive disorder. Sertraline. The difference with sertraline is that it causes more GI symptoms, right? That's why we call it squirtraline. For whatever reason, sertraline causes more diarrhea. So if a patient has a very sensitive stomach, I probably won't prescribe them sertraline as a first line, right? I would try something different, maybe Lexapro, or maybe Celexa, or maybe even Prozac. All right. Prozac is significant because it's the only medication that's FDA approved for children as young as age 7. So when I see kids that are as young as age 7, I usually would prescribe them Prozac, right? The important thing to know about Prozac, it's also a very potent 2D6 inhibitor, right? The problem with Prozac is not only is it a 2D6 inhibitor, it also has a very long half-life, right? Fluoxetine gets metabolized by 2D6 to norfluoxetine, NOR fluoxetine, right? Norfluoxetine's half-life is very long, much longer than actually fluoxetine itself. So what happens is after a while, when you take fluoxetine and hit steady state, norfluoxetine will hit steady state as well, and norfluoxetine itself will stay in your system, which also it's a 2D6 inhibitor. So an example is a patient stops fluoxetine 2 weeks ago, all right? You give them a medication that's a 2D6 substrate, aripiprazole. You still need to adjust that aripiprazole because there's still going to be Prozac or fluoxetine in the system, right? Because of the very long half-life. It needs to be a 1-month washout period, at least. So maybe don't start Abilify 5 milligrams, or you're going to get a Macrothesia or EPS. Maybe start it at 2 milligrams, right? And the reason for that is the Prozac is a 2D6 inhibitor, very long half-life, stays in the system. It can still affect all the other meds, right? That could be antipsychotics. It could be beta blockers, right? The primary care doctor puts them on metropolol for blood pressure, right? They take metropolol, all of a sudden they're gonna be hypotensive and bradycardic, right? Because of the Prozac. They have to cut that dose in half, or maybe even less than that, right? Venlafaxine is an SNRI, and duloxetine is SNRI. We usually use that for depression and for people who have comorbid pain symptoms, right? Neuropathic pain. Because norepinephrine works in their dorsal root ganglion, right? And then what it does, it inhibits the pain pathway, right? Just to make it simple, your pain pathway has to go up afferent neurons, right? That afferent neuron is in your dorsal root ganglion, right? So when it goes up to your brain, that's when you feel pain. When you increase norepinephrine, it's going to go down, and it's going to give an inhibitory pathway. So that's why it dulls down neuropathic pain, all right? So norepinephrine will help with pain. Serotonin does not. So if you give someone an SSRI, it's not going to work with their pain. Give them an SNRI, it's going to work for the pain, all right? Usually we use duloxetine, but sometimes they can use milnacipran and levomilnacipran as well, all right? That's an SNRI as well, all right? Amitriptyline, TCAs, just know they're dirty drugs. We still use them, and sometimes we do use them for treatment-resistant depression if people have really bad depression, but they're dirty drugs that they affect other pathways we don't want them to affect, right? Anticholinergic, constipation, dry mouth, right? Blurred vision, urinary retention, all right? Cognitive issues. So we try to reserve that. And also the suicide risk is much higher because they can overdose on that, all right? So they affect serotonin, norepinephrine, and those other pathways. Also alpha blockers, so orthostatic hypotension. You should look out for that as well, okay? Doxepine, tricyclic, we use that usually off-label for insomnia. It's a very good antihistamine, especially at low doses, okay? Nortriptyline has a little bit more norepinephrine activity, so we use that more for pain, right? Nortriptyline is used a lot for pain. Questions? Side effects of antidepressants, all right? Sexual dysfunction is probably number one. Always ask your patients about that, okay? Because they might be afraid to mention it. Again, bleeding risk if it's combined with other anticoagulants. For SNRIs, make sure you do liver enzyme, ALT, AST, because it can cause spontaneous liver.
Can I keep it up because I don't have the headphones?
Excuse me, question? Check liver enzymes if you're ordering an SNRI, okay? Also for SSRIs, which I didn't put here, check for hyponatremia, okay? Especially if they're taking carbamazepine. It can cause the body to oversecrete antidiuretic hormone. What happens? You retain water, and what's going to happen is your sodium levels are going to go down, all right? So make sure you check sodium levels if someone's on SSRIs with carbamazepine or any other meds that can cause hyponatremia, all right? Hyponatremia side effects could be confusion. It can eventually lead to seizures if it goes unchecked for such a long time. Speaking about seizures, DNRI, Wellbutrin, all right, be careful with that with patients who have risk of seizures, head injuries, active eating disorders, all right? Any other medications that can lower the seizure threshold, okay? Avoid heavy alcohol use with Wellbutrin because that can really cause a seizure as well, all right? Okay, we already talked about tricyclic antidepressants. All right, bipolar, we're really going to focus on this now, all right? So bipolar disorder is the opposite of depression. And sometimes patients might not really be, open about it because sometimes hypomania, particular, people feel well, right? They're like, what's wrong with me? There's nothing wrong with me. I can go 4 or 5 hours without sleep. I'm very productive, right? There is a subset of people that have hypomania and they're functioning, doing okay, right? These are the people that work in the hospital. They could be surgeons, they could be nurses, and they'll do double, triple shifts, and they're fine. Drink a cup of coffee. They might take a nap in the break room, and they're okay. They're functioning, all right? But sometimes their depression can be really bad, though. That's the problem. They could be functioning when they're hypomanic, but when they hit a depressive episode, it gets really bad, right? They could be suicidal. They could just lay in bed all day, not shower, not brush their teeth, not do anything, almost like a vegetable. So it's important to ask and be very specific. Have you ever had days in which you had less than 7 hours of sleep and you still felt like you were functioning, right? Have you ever had days where you spent so much you bought things you didn't need? I had a patient that went on Amazon and I think she said she bought like 8 toilet seats because she just liked the colors. She bought all 8 colors, and I was like, why do you need 8 toilet seats for? So I don't know, I just felt like buying them, right? You speak to the spouse. You can say, is there ever days where your husband is like late with the rent and they can't pay, or the opposite? I don't want to be sexist, but where your partner can't afford to pay the rent. You guys split it in half, and they always say, can you pay it this month? I'll pay you back next month, right? Because again, they're spending their money on other things, right? Are they gambling? Are they having promiscuous behavior? Increase in pleasure-seeking activity when they're manic. All right, anything that causes pleasure, whether it's substance use, sexual activities, risky behaviors, driving fast, right, in the highway. Are they distractible, right? When you talk to them during an interview, you constantly have to kind of redirect them, all right? Usually when someone's manic and they're having flights of ideas, it's flights of ideas because you can't distract them, right? You try to cut them off and they keep talking nonstop. Usually that's full-blown mania, all right? Are they irritable, right? You can ask the partner, are there days in which maybe for a week or two, they get very angry over little things and you feel, and you see them talking fast and they're not sleeping as much, right? Sometimes I'll ask people, it might sound silly, but you might ask people, do you have any special powers? Do you ever had a feeling you could do things other people can't do, right? Some people might say, yeah, they're in my job, I'm the only one that can do this. And, I'm the only one that can juggle 4 or 5 things and get stuff done. And you kind of have them explain it more, right? I spend all-nighters, I'm up 3 days and, I work for 3 days straight and I'm fine. I get a lot of stuff done, right? Maybe they're hypomanic or maybe they're manic, right? Once again, sleep decreased with energy is the key word, all right? Someone cannot be sleeping, but they're taking naps during the day. That's not mania, all right? All right, I was up all night last night. Okay, did you take a nap the next day? Yeah, I was so exhausted. I take a 2-hour nap, 3-hour nap, right? That's not, most likely that's not mania, right? Any questions with that? Okay. We're going to stay in this for a while, okay? We're going to break down each medication and we're really going to focus on lithium as well. Valproic acid. Be careful with valproic acid with females of childbearing age. That's a good test question. They'll usually ask that. Yep, someone's asking me a question on the chat. Can you guys hear me?
Yeah, I can hear you.
Yes.
Yeah.
It's clear.
Lori, I don't know. Lori Serrani, I'm recording this, but I don't know why you can't hear me. No, nothing wrong with my mic. Sorry. Okay. Valproic acid, contraindicated in women who are pregnant, should not be used or used sparingly in women of childbearing age. The reason why is because there's a very high likelihood of causing birth defects. Also increases the risk of autism, intellectual disabilities, spina bifida, you name it, it causes a lot of malformations, right? So I'm in charge of a perinatal clinic as well, and I oversee that program. So we have practitioners there, and I make sure that people who are in Depakote are not prescribed that, or there has to be a good reason for them to be in Depakote. If it's the only medication that works for them, but again, it has to be documented that we've tried everything else, and if they're not on Depakote, they're risking themselves or others. But remember, there's always going to be a risk to the fetus as well. Okay. What Depakote does is it does a few things. Well, one of the things it does is it reduces folate levels. All right. So at the very least, anyone who's in Depakote should be supplemented with folate. Okay. Yes, Jessica, question. Yes,
So what
Jessica.
are the special precautions that you would use? Because like my job, we have an adolescent female unit. And actually significant amount of them are on Depakote. So would we do like specialized teaching or?
Yeah, usually if I have an adolescent female who's on Depakote, I make sure that number one, if they're sexually promiscuous, that they should be on birth control, right? Just to make sure. And that I educate them and I document and I educate the parent that this medication has these risks. If you plan to get pregnant, let me know, and then we can switch your Depakote to something else. All right.
Okay,
It's used, but there's precautions for it, right? Yeah. So Depakote is also significant because it's a histone deacetylase inhibitor, HDAC inhibitor, right? It sounds fancy, but really all that means that you need histone deacetylase for cell division, all right? So when you inhibit histone deacetylase, you're impairing cell division. So they actually use Depakote in cancer treatment, right? Because it messes with cell division. But you need cell division when you're getting pregnant, obviously, right? That's why there's a lot of cognitive congenital issues, because when the cells are not dividing, you can have a lot of issues there, all right? Also, people with Depakote, they can lose their hair. Obviously, it can cause weight gain, sedation, all right? If someone's on Depakote, they should not stop it cold turkey, right? It's an anticonvulsant. What happens if you stop an anticonvulsant cold turkey? You can have a seizure, even if you don't have epilepsy, all right? So we had a patient one time that she actually tried to overdose on Depakote, and then they didn't taper off it, and she had a seizure. All right, so it has to be weaned off. In general, most of our medications should be weaned off. All right, because remember, when you're working on the brain and you have upregulation, downregulation of receptors, you need to give your brain to adjust to that, whether it's to the upregulation or the downregulation. All right, so make sure that you educate patients on that. You should not be stopping your meds cold turkey. All right, once again, normal Depakote levels, 60 to 120, 50 to 120. I've seen also anything in that range. All right, is normal Depakote level. Okay, be careful with Depakote because it's highly protein bound. Okay, for instance, let's say you do a Depakote level on someone and it's 80, right? All of a sudden you find out that this person, I don't know, adolescent female, right? Pretty common. Someone called them fat. Now they're like, oh my God, I'm fat. I'm going to stop eating. Starts restricting. After a while, albumin levels are going to start going down. What's going to happen at a Depakote level? It's going to spike up, right? Because if you don't have enough albumin for the Depakote to bind to, you're going to have a much higher free valproic acid level, right? All that free valproic acid is going to go up. It can cause toxicity, all right? Depakote also has a high risk of pancreatitis. So make sure you rule out pancreatitis, especially someone who has abdominal pain, all right? Remember, abdominal pain, 2 inches above the umbilical area, right? That radiates to the back with nausea, vomiting, and fever, okay? You should probably send them to the emergency room just to be safe because they're on Depakote, and you should rule that out, okay? That's a medical emergency. Any questions with Depakote? Yes, Alex.
Hi, Professor. All right, I remember that some of the psychiatrists and providers, they are very permissive with the Depakote level. I think that is, for example, if the Depakote level is 140, or they're just permissive. It's not like they are not as rigorous as with lithium. How is that part of the loading dose, or generally speaking, how much how high the level can be with Depakote?
Okay, I'll answer both your questions. Depakote can be loaded. The reason why I used to work inpatient for a long time. I worked at NYU inpatient hospital and inpatient site. We used to load Depakote when patients were very aggressive. So it's a good medication because it causes sedation. So if someone's aggressive and you really want to calm them down because they're like beating up nurses or beating up the other staff, Depakote is a good meds to use. But after a while, you need to kind of like reduce the dose and bring it down. So you've seen someone stable on Depakote 140? Is that what you're telling me?
I can remember right now somebody specific, the level specific, but I think it was higher. I think that, yeah.
Well, assuming that Depakote level truly is 140, right? Remember, the problem with levels is that it has to be timed correctly, right? When that level was done, was that actually 12 hours after the last dose? Because sometimes the phlebotomist will come, right? And I'll say, oh my God, Depakote level is like 140 or 150. But then we'll find out the phlebotomist came early and the nurses gave the medication a little bit later that night, right? So it's not 12 hours post-trough, right? Which we want from the medications. If the patient's stable and not having any symptoms of toxicity, right? And ammonia levels are normal, there's no hyperammonemia, they're not confused. there's no there's no GI symptoms, I guess it's okay. Answering your question why providers are kind of, they don't care about Depakote levels, I don't know why they should. That means they're not sophisticated prescribers, and you guys are not going to be like that, right? So you want to make sure that if the patient's fine, I'll probably do a repeat, just check it again, because it might not be 140, it might actually be like 110 or 120. All right. But remember, the higher that you go in the Depakote, I would say above 80 or even 90, and you're getting very close to the threshold, be cautious with their nutrition, because once if they're not in the hospital, they're not getting adequate nutrition, or they have an eating disorder, and the albumin levels start trending down, Depakote can shoot up very quickly. Right, giving them the same dose, but there's not enough albumin there for the medicine to bind to, and they easily can get Depakote toxicity. Does that make sense?
Yes.
Yeah. So I might not be as scared of that if their Depakote level was like 55 and they were stable, right? But if a Depakote level is like 80 and any change in albumin level could really shoot it up, then I would be more cautious with that patient. All right. Yes, Jacob, question.
Yes, just to clarify, so when Depakote is bound to a protein, it's basically it's in its inactive form, and therefore you need them to be nourished to keep the protein up once they're not once they're malnourished, or if they're homeless, let's say. So you want to be careful, because then the Depakote could become an overdose.
Correct. I see this a lot too. Patients will come to me from other people, NP, psychiatrist, doesn't matter, and they'll be on like 500 milligrams of Depakote, right? And they say I'm fine. Most of that Depakote at 500 milligrams, most likely is bound to the plasma protein, right? In reality, it's probably doing nothing. Maybe only if you do a level, it's probably like 20 or 30, right? Not even enough to make it to the brain. So it's in reality, it's probably a placebo. In that case, I will tell them, let's just stop the Depakote then. There's no reason for it, because the risk of you getting pregnant, because you can still get side effects even if the medicine is not therapeutic, right? So the risk and benefits ratio is way above for the risk than it is for the benefit, because I know at 500 milligrams of Depakote, it's probably not doing what it wants to do, because most of that's going to be bound to the protein. What you need to do is take enough of the Depakote, PO, for it to flood your plasma albumin, so that once all those binding sites are flooded, whatever is not bound is going to go up to your brain. Does that make sense? If you don't give enough to bind all the albumin, none of it's going to make it up to your CNS. It's like taking a placebo. Does that make sense?
Yes, thank you.
I forgot the ratio, but depending on what the Depakote level is, the higher that you go, the percentage that's actually making, let's say for instance, your Depakote level is, I'm just giving an example, right? Just not specific, but just to give you an idea of what I mean, is 80. That's a total Depakote level, right? Maybe only 20% of that is actually making it to the brain. So in the plasma, in the whole body, it's 80, but maybe if you were able to do a level that's in the CNS, it's probably only like 15 or 18, right? Now, when the level goes up to like 120, in the on the total Depakote level, right? All those albumin proteins are going to be bound with Depakote. Maybe it's going to be 60 in the brain, right? So more of it actually. So the reason why I'm saying that, Depakote does not have a linear pharmacokinetic. Linear means that when you increase the dose, the levels go up correspondingly. Let's say, for instance, something that's linear, you give someone 5 milligrams of a medication, right? And the level is 5. Make it easy, one to one. You give them 10 milligrams, the level should be 10, right? You give them 15 milligrams, the level should be 15, because it's a linear pharmacokinetic. It's non-linear in the fact that once you saturate a certain amount of plasma albumin, the level could really shoot up a lot. All right, so it's not linear. So be careful as you're titrating Depakote. As you get higher in level to that threshold, don't increase it a lot. Maybe go by like 250 or 125. Don't just go like 500 milligrams Depakote, 1,000 milligrams, 1,500, 2,000, 2,500. I would be very cautious based on the level. Does that make sense?
Yes. Yeah.
Very good. So Depakote is FDA indicated for bipolar mania, not for maintenance, not for depression. All right. So if someone's acutely manic, Depakote would be a good medication for that. Okay. It comes in multiple forms. We have delayed release, right? We have extended release, and we have the liquid, right? Which is actually immediate release. You can use the liquid. The problem with the liquid is that it's absorbed in GI tract, and it can cause a lot of GI symptoms, right? So just a general understanding of medications. any medicine that's absorbed in your stomach or the proximal part of your small intestine can cause a lot more GI side effects, right? Usually you'll see nausea, vomiting, right? Anything that's absorbed lower in your GI tract can cause what? Diarrhea, right? So the delayed release, it's going to be delayed because it's in a wax film that needs to be that needs to make it down to the distal part of your small intestine, right? It's going to be causing more diarrhea, those side effects. So based on your patient's side effect profile, you would choose which one, right? Obviously, if you think they're cheating the medication, I would probably give them the liquid form, all right? That's what we do in inpatient. Any questions with Depakote? We spoke a lot about it, but that's just, yeah.
I have a quick question. Can you hear me?
Yes, I do.
Okay. I know that malnutrition can affect the drug levels, but I've tried to find, can a high protein diet, a lot of people are doing that, can that affect it the same, like the opposite way?
You know, that's a good question. I don't want to give you the wrong answer. I'm not sure. I'm going to research that. I'm not sure. You mean like someone who's like doing keto or something? Or a high protein diet? I don't even know what a high protein diet is actually. I'm not sure. Question? Someone has a question? Alex, question?
Yes, Professor. So valproic acid, no for maintenance, and no maintenance, no depression. Just you mentioned that, right?
Yes. So look at this chart. Only bipolar mania. Okay. Remember, for the class, you might see people practicing differently because we do use a lot of things off label in psychiatry, but just to get your test question right, go by what's FDA indicated for now. Okay, so if there's a question that says, can you use Depakote for someone who is euthymic for maintenance, the answer would be no. You might see that in clinical practice, but for the test exam, it's not FDA indicated for it, so the answer would be no. Okay, like I said, lithium, we routinely use it for bipolar depression. I use it routinely for bipolar depression, but it's not FDA indicated. I use it off label. Okay, so for a test question, only for mania and for maintenance. Okay.
So when you say no for maintenance is what do you mean? I'm sorry.
Okay.
Not for
Bipolar
maintenance.
disorder has three parts, right? Think of it like a seesaw. Either they're very high, so you need to stabilize them from the top down and bring them down, right? Or they're very low and they're very depressed, and when you're bringing them down up to the middle. Okay, think of maintenance as the middle. Maintenance means someone is not in active depression or manic right now. They just want to stay well, right? You know what? I haven't had a manic episode, depressive episode in a while, but I'm afraid that it's going to come back. Okay, so we need to give you a medicine that's going to be for maintenance, right? We can put you on lithium. We can put you on lamotrigine. Does that make sense? So maintenance is stopping a mood episode from happening. They can still happen, but it's going to reduce that likelihood of happening. That's maintenance when they're euthymic.
Okay, so generally speaking, once a patient is stabilized, we make that transition to lithium or lamotrigine. I mean,
but we don't always see that. And the reason why is because usually, let's say, I'll give you an example. Patient comes to you who is acutely manic, right? Inpatient hospital. Happens all the time. You get them on Depakote and, you get them out of their mania. But now you want to discharge them soon, but you need to put them on a medicine that's also going to keep them maintained. You're probably going to put them on Depakote and, lithium, right? You see that pretty commonly. You can prescribe both at the same time, right? You can use Depakote with lamotrigine, but what? There's a caveat there. Anyone know? I use it too, but there's a caveat there. If someone, it's important, I'm going to say this 5 times because it's important. If someone's on Depakote and you're giving them lamotrigine, okay, there's an interaction with Depakote. It's not CYP enzyme mitigated. It's actually mitigated by phase 2 metabolism, which is the UGT system. All right, I don't have time to talk about that right now, but the UGT system is phase 2 metabolism, right? They share the same phase 2 metabolism property. So Depakote will actually inhibit the metabolism at phase 2 of lamotrigine. So you have to cut lamotrigine doses in half. I'll say it again, just to make it simple. If someone is on Depakote, you can add lamotrigine, but you have to do it at half the dose and titrate it much slower, double the titration, okay? Because if you don't do that, the risk of Stevens-Johnson syndrome is going to go up drastically, all right? Someone's on Depakote, you can prescribe the lamotrigine, but make sure you cut the dose in half. So normally with lamotrigine, we'll start what? 25 for 2 weeks, all right? Do you have a rash? No. Okay. 50 for 2 weeks. Do you have a rash? No. Okay. 100 for a month. Do you have a rash? No. Okay. 150 for a month. Good. 200. Climb your way up. Okay. If someone is on Depakote and you're doing that same titration, you can't do it that same way. You might say 12.5 for 2 weeks. All right. 25 for 2 weeks. 50. Understand? I'm just doing it much slower because I understand that the Depakote is going to, in a way, impede the metabolism of lamotrigine in half. So you need to adjust the lamotrigine much, much lower, or else you can increase the risk of Stevens-Johnson syndrome. Does that make sense? Because it makes sense. Look, you need someone that's going to help control the mania, and you need something to help with maintenance. So that's a pretty common practice. Just be careful that you go slowly with the titration. Okay.
Okay.
Okay. Lithium. Know that Depakote could be toxic to the liver, right? So you make sure you check transaminases, ALT, AST. Normally, ALT, AST will be elevated. That's normal. But if it's 3 or 4 times elevated, I would probably refer them to a specialist just to see what's happening. All right. So ALT, AST normally is in the 20s. Okay. If it's triple that, let's say it's like 60 or 80 or even 100, I would probably refer them. Okay. Especially if there's other signs also, like abdominal pain, just to make sure. And I would probably hold the Depakote, right? Make sure they don't have pancreatitis. Okay. Lithium. Lithium could be hazardous to the kidneys. Okay. Lithium was actually one of the first most effective medications that were discovered for bipolar disorder. All right. So it was an Australian psychiatrist named John Cade. All right. And he found out, and what he was doing was kind of interesting. He thought originally that, a lot of people thought that the cause of mania actually had to do with uric acid, right? Gout. And he thought that by curing gout, that it would actually help with mania. But guess what? You can use lithium for gout, but by reducing the gout, he thought that it was helping with the mania. But then when he found out later on that when he was giving it to other people that didn't have gout, that actually it was helping with their mania, right? So it's very interesting. It's called a serendipity, right? Serendipity is usually how we find a lot of our medications, right? We make a medication for, I don't know, I'll use Thorazine as an example, right? They needed a medication to help people for preoperatively for surgery to calm down and relax, right? It was a preoperative anesthetic. They found out that all the patients that had psychosis or mania were given Thorazine. For whatever reason, they stopped becoming manic or they stopped becoming psychotic, right? So someone was like, wait a second, we give them medicine for this and it's doing that, right? So a lot of times that's how we find new meds, right? You make a medicine for something else, but it has another effect, right? So with lithium, since the advent of lithium, a lot of people have been out of the hospital. So people have been able to kind of function, not be institutionalized. Same way with antipsychotics, right? People who had quote unquote MDI, manic depressive illness, they had to be institutionalized their whole life, can actually go out now in the community, right? Because of lithium. Lithium now is under prescribed. I think last stats I checked, I think for people who would benefit from it in America, you prescribe it less than 10%, right? People who have bipolar disorder, for instance. In Europe, they prescribe lithium at least 50% to their patients. They utilize it a lot more. And there's many postulations for that. I mean, they think that because obviously it's generic, drug companies don't really have incentive to market it, right? Lithium is a natural, element. There's no money in it, so therefore they kind of dissuade us from prescribing it. But it's a very beneficial medication. It's one of the only meds in psychiatry in mood disorder. I'm going to say that again. It's the only medication in psychiatry in mood disorders, which is MDD, bipolar depression, and mania, that is shown to reduce suicide risk and suicidal behaviors. All right. That's important. So if anyone ever has a history of suicide attempts, I would offer lithium. Okay. Even if they don't want to take it, let them know. It's your obligation to. It's the only med that we have. And I have patients that suicide their whole life. Put them on low dose lithium for MDD on top of their SSRI. And for whatever reason, their suicidal thoughts go away. Okay. Lithium, once again, could be hazardous to the kidney. So you want to make sure that kidney functioning is okay. All right. So you make sure you check BUN, make sure you check creatinine, and make sure, most importantly, you check GFR, glomerular filtration rate. Okay. If GFR goes below 50, you need to stop the lithium. All right. You're probably going to see that more with older patients, but someone who's young can have kidney issues as well. So make sure you warn them about that. Okay. How do you start lithium? Okay. I usually start lithium by giving them 300 milligrams for about a week. All right. 300 milligrams immediate release. Okay. The reason why I'm using immediate release, why do you think I'm using immediate release? Tell me. What's the advantage of immediate release as opposed to extended release? Why do you think? Okay. Your kidneys need a little bit of trough time to relax, right? Think about it. When the medication is going down and it's troughing, right, that means the levels are going down. Your kidneys are getting a little break from metabolizing that medication or working on that medication, right, for instance. If you give them immediate release, the half-life immediate release is about 21 hours, right? 18, 21 hours, 22 hours around there. So you get a couple hours of a break of your kidneys not metabolizing, right? If you give them extended release, it's almost 24 hours. Your kidneys are working on that medication constantly, right? And the trough time is much less. The reason why I bring that up is lithium should be dosed once a day at bedtime, right? I know that's not what a lot of people do, but lithium should be dosed only at bedtime. And the reason why that is, if you do lithium twice a day, your kidneys are working overtime, and the risk of developing kidney issues are going to be a lot higher, all right? So if someone can tolerate it, what I'll do is I'll bridge them from twice a day dosing, obviously, because if you go too fast, too soon, and you give them one dose all at bedtime in the very beginning, they could have nausea, right? Which is the most common side effect, or diarrhea. So just to get them used to it, I'll do twice a day dosing, and I'll convert it to once a day dosing once it's stable. Does that make sense? Any questions? So 300 milligrams, right? What is the half-life of lithium? I told you, it's about 24 hours. It's about 1 day, right? Give or take. So you should do lithium levels, 5 half-lives, right? And it hits steady state. So about a week, right? 5 days to 7 days, you do your first lithium level. Does that make sense? Depending on lithium level, you're gonna raise it up again. Obviously, the practice inpatient and the practice outpatient is a little bit different. If you're working outpatient, you can do what I'm saying, do 300 milligrams for a week or even 2 weeks, go slowly. But if it's inpatient, you might load them a little bit. You might go a little bit faster. And the benefit of that is because you have nurses around the clock who can check lithium toxicity. If you're doing outpatient, someone could be lithium toxic and you're not going to know, so you can go much slower. So outpatient, we can go much slower. Inpatient, obviously, we go a little bit faster, okay? Normal lithium level, like I said, half a dozen to a dozen, 0.6 to 1.2. Okay, if someone's acutely manic, you would probably go a little bit higher, right? Some recommendations say going above 1. Some recommendations say go above between 0.8 and 1.2 for acute mania, right? For maintenance, keep it a little bit lower. So if someone's acutely manic, right, we keep the lithium level above 1. Let's say 1.1, all right? Once they're stable, they're not manic anymore, we should bring it down to a maintenance dose. So bring it down to keep it between 0.6 and 0.75. Any questions with that? Okay. Lithium contraindications, okay? Lithium doesn't have too many contraindications, all right? But there are some big ones, okay? Obviously, kidney impairment. If someone doesn't have good kidneys, you should not be giving them lithium, okay? Another contraindication, all right? Someone who has cystic acne and psoriasis, all right? Not really a big contraindication, like medically, but patients are not going to take it, and you're going to ruin their life, all right? If you give a teenage female who has cystic acne lithium who wasn't depressed, good luck. You're gonna give them cystic acne, you're gonna ruin them, right? Make it much worse. Do not. So once they have cystic acne, I would not prescribe lithium to them. Okay, psoriasis as well, right? Someone who has sick sinus syndrome, all right? Sick sinus syndrome means that their SA node is not working appropriately. If you give them lithium, it's going to shut down the SA node, and your heart is only going to rely on AV node conduction. And the AV node heart rate is about 30 to 40. So that person is not going to be able to live with that heart rate, okay? Sick sinus syndrome, no lithium, okay? Impaired kidneys, no lithium. Cystic acne, psoriasis, most likely do not prescribe them lithium, all right? Long-term lithium use can cause hypothyroidism. So before you start lithium, make sure you do a baseline TSH, all right? Number 1, TSH levels. Because you want to make sure they don't have hypothyroidism even before you start the lithium. Because you want to know, is the hypothyroidism due to the lithium, or did they have hypothyroidism before lithium was there, all right? You should also check CBC. Why is that? What does lithium do to CBC count?
EFR. Oh, no, I'm sorry. That's it.
CBC is complete blood cell count, right? What does it
Yeah.
What does it do? Increases your white blood cell count, all right? So the reason why you don't want to do a CBC is because you want to make sure that the CBC is normal before you start the lithium, all right? Because obviously if it's normal before you start the lithium and you start in the lithium and they have leukocytosis, which is normal, it's fine. You know, it's induced by the lithium and it's fine, right? They actually, you know, they have some studies out there where lithium can actually reduce people from catching COVID. There was actually a study they had with people who are on lithium for whatever reason, they were less likely to catch COVID. That's because it increases your white blood cell, your immune system in general is just very active, all right? Sometimes we use lithium as well as an adjunct to clozapine. It's a little advanced, and I'm gonna talk this a little bit more. When I prescribe clozapine and someone's white blood cell count starts to go down a little bit, I use lithium off-label because what it does is stimulates your bone marrow to secrete more white blood cells, right? Your bone marrow is gonna create more white blood cells, and it's gonna balance that out. So you can use that as well. It's a little advanced technique, but we can use that, okay? Lithium, make sure you check TSH. Make sure you take CBC, okay? And after a while, long-term lithium use can also increase parathyroid hormone. So make sure you check calcium levels, all right? Questions? Okay, so lithium is not that hard to prescribe. I don't know why people are afraid to prescribe it. You know, I mean, if you do it slow and you're monitoring and you're checking it pretty regularly, I mean, it's a fairly safe medication that can actually change people's lives. Again, it helps with mania, off-label can help with depression, and it's also for maintenance. All right. If there was one monotherapy that patients could stay on and just be on one medication, it's probably gonna be lithium, most likely. Because it covers, you know, all three ends of the spectrum. But unofficially, yes, Jacob, question.
Yes, what about pregnant women? Is it like safer than Depakote?
Lithium is, yes, I'm sorry, I wanted to bring that up as well. Lithium is most dangerous during the first trimester because it can cause something called Epstein's anomaly. All right, it's a low implantation of the tricuspid valve. Think of LIT from lithium, low implanted tricuspid valve. That's called Epstein's anomaly. And that only happens if you take lithium during the first trimester. All right, after the first trimester, you can put them back on the lithium. All right, because that risk is gone. But once again, that should be done in consultation with the OBGYN, and I've done that with patients too. Depakote is contraindicated throughout the whole pregnancy, even before when you're trying to get pregnant, all right? Lithium, first trimester. But in a test exam, just to be cautious, lithium shouldn't be given in pregnant women, just to be cautious. In clinical practice, it can be, when monitored correctly, all right?
Okay, thank you.
Lamotrigine. The most important thing about lamotrigine to know is Stevens-Johnson syndrome, all right? It's a skin rash that can develop to your skin falling off. You almost look like a burn patient, all right? It's an autoimmune response that your skin starts, like your body starts fighting off your skin and your skin will actually slough off, right? It's a medical emergency. Normally it doesn't happen that quickly, right? That's why, you know, we do a very slow titration and we have the patient check their skin, right? Daily skin exams. Make sure you check if there's any rashes. And really the rash that we look for is a rash that has systemic issues, all right? Is there fatigue? Is there fever? Is there joint pain together with a rash that's on your face that has irregular borders, might have some redness to it, you know, not just a typical rash that could be dermatitis or psoriasis, right? Just to be safe, I usually will send them to the primary care doctor just to get second eyes, especially if I'm not seeing them in person, just to see, all right? And make sure that before you start lamotrigine, make sure you tell your patient or you check them for any rashes on their body already, right? If they're prone to rashes, right, you should document that because you want to make sure that it's not the lamotrigine causing the rash. It wasn't there before, all right? Lamotrigine, once again, is FDA approved for maintenance, but it's used off-label for bipolar depression. It has no coverage for mania, all right? There are actually case reports of people getting put on lamotrigine that have become manic. All right, so you usually have to put coverage for mania as well on lamotrigine. Okay, any questions? Carbamazepine. Okay, the important thing about carbamazepine is that it's a very strong inducer. It's FDA approved for bipolar mania. Okay, it's a very strong inducer, so when you put it on board, make sure that you adjust the levels accordingly of the other medications they're taking, because you might have to increase them because carbamazepine is going to eat up those medications. Yes, Jessica, question.
Lamictal, sorry, we're on two computers at the same time. The Lamictal,
Yes, what about lamotrigine? You're breaking off. I can't hear you, Jessica. Say it again.
sorry, we're on two computers. The Lamictal, you said use it for mania or don't use it for
No,
mania?
don't use it for mania. It has no coverage for mania at all. It doesn't do anything for mania.
Okay,
Only for the test exam, only for maintenance. In clinical practice, you can use it for bipolar depression. Right? Always refer to this chart because these are the FDA indicated use of the medications, okay? Carbamazepine, very strong inducer, all right? So it's going to mess up the regimen of all the other meds that the patients are taking. So make sure you adjust them accordingly. It also induces its own metabolism. So when you do a carbamazepine level, make sure you check it again a couple of weeks after when you get it, because you might have to adjust the carbamazepine again because it eats up its own metabolism. Does that make sense? All right. Carbamazepine can also cause agranulocytosis similar to clozapine. The risk is much lower, but I would still check CBC, all right, with carbamazepine. Another thing you should check for carbamazepine is hyponatremia. I mentioned that before. All right. It can affect ADH, and your body will start retaining water. Therefore, sodium levels are going to go down equivalently. Okay. So once you start seeing hyponatremia, make sure you adjust it accordingly. Okay. Especially if they're taking SSRIs as well with that. Olanzapine. Olanzapine is an atypical antipsychotic. All right. Very effective. Problem with olanzapine is what? What does it do to people? Blows them up. Right? Olanzapine and clozapine are the most notorious for weight gain. So usually I'll start prophylactic metformin, right? Just for your information. I use metformin in the beginning prophylactically to help mitigate the metabolic issues of olanzapine. Okay, olanzapine is a very strong D2 antagonist and also a very strong 5-HT2A antagonist. It's a second generation antipsychotic. What that means is that it has less risk of EPS because of the 5-HT2A antagonism, right? 5-HT2A is a autoreceptor, right? When you block 5-HT2A, you actually increase the secretion of dopamine in the nigrostriatal area. So it combats the EPS. So for instance, the olanzapine might be bound to the D2 postsynaptic receptor in nigrostriatal area, right, to the striatum. But at the same time, it's also blocking the 5-HT2A receptor. So it's increasing the amount of dopamine secretion. So it kind of negates it. Does that make sense? So if you just gave someone a D2 blocker without a 5-HT2A antagonist, you can increase the risk of EPS because you're blocking dopamine receptors in the movement pathway, the nigrostriatal area, right? By giving them a 5-HT2A antagonist at the same time, you're blocking the autoreceptor, increasing dopamine in the nigrostriatal area, and therefore it negates EPS. Does that make sense? Okay. Olanzapine is also a very potent antihistamine, so it can cause sedation. Antihistamine, not only does it affect your histamine receptors in your brain, it also affects your hypothalamus. Histamine and hypothalamus kind of disrupts your leptin, right? And your ghrelin. Leptin is what? Leptin is what makes you full. Ghrelin is what makes you hungry. So patients on olanzapine, they might start eating more, right? They don't feel full, and they're always hungry. So make sure you tell them that, all right? Stay away from soda. Try to drink a lot of water, right? Try to exercise. Healthy diet. Easier said than done, but they should be aware that olanzapine can cause weight gain, all right? I would start metformin, 500 milligrams a day, move it up to 500 milligrams BID, and eventually push it up all the way to 2,000 milligrams of metformin a day, just to counteract the weight gain from olanzapine, all right? Olanzapine by itself is indicated for mania and for maintenance, but olanzapine plus fluoxetine combination, also called Symbyax, is actually approved for bipolar depression. I know I told you guys do not use SSRIs for bipolar depression, but for whatever reason, there's something magical about the combination of olanzapine and fluoxetine. It's the only SSRI in combination with olanzapine that's shown in studies and FDA approved to help in bipolar depression, all right? But any other SSRI should not be prescribed in bipolar depression, except fluoxetine with olanzapine in combination. Do not give fluoxetine by itself in bipolar depression. You can give it with olanzapine together. That's called Symbyax. And the ratio, I think, is like 2 to 1. All right. 2 SSRI to 1 of the antipsychotic effect. All right. Any questions? Am I going too fast?
Can you just repeat the what you said about olanzapine and the 5-HT2A receptor pathway?
Right. Yeah, sure. 5-HT2A is a serotonin receptor, right, on a dopamine neuron, right? Or also, I'll just keep it at that. There's an interneuron there, but I'll keep it simple. When you block a 5-HT2A autoreceptor, right, it's going to increase dopamine in the motor pathway. So anything that's a 5-HT2A antagonist, you should think, okay, less EPS. Not zero EPS, right? Because that's what the pharma companies want you to believe. It's not true. It's less EPS. Olanzapine, though, at high enough doses can cause tardive dyskinesia and other EPS symptoms. All right. So anything that's a 5-HT2A antagonist will help negate the side effects of movement disorders from the D2 antagonist. Does that make sense?
Yes.
So olanzapine, because of the antihistamine and also the 5-HT2C, serotonin 2C receptor, can cause weight gain. So any meds that are 5-HT2C antagonists and antihistamines can cause weight gain. All right. The exact mechanism of how 5-HT2C causes weight gain is not fully understood, but once again, we think it has to do with leptin and ghrelin.
Does the pathway have to do with, so the receptors, the 2A and the 2C, are they located on the GABA? Does GABA play a role in
Yes,
this?
they are also on the GABA. Exactly. That's what I mentioned interneuron, but I have to draw it out. For me to just say it to you guys, it's hard for you to visualize it. So just to keep it simple, I'm just making it simple. And 5-HT2A antagonism will increase dopamine in the nigrostriatal.
I almost feel like I should just
It
say
is on a
yes,
GABA interneuron.
and then we can get up there and do it again.
Did I answer your question?
Yes, thank you.
Sorry, if we had pictures, but I just want you kind of, again, we're gonna keep repeating this in your career as you guys go to clinical part 2. So this is more of just having a general understanding here, all right? So anything in general, blanket statement, that's a second generation, olanzapine, risperidone, quetiapine, right? Ziprasidone, these are all second generation atypical antipsychotics. They tend to have less EPS, and we do use those. The advantages of using these as opposed to mood stabilizers, right, is that sometimes they could work a little bit quicker. So sometimes if you give someone a D2 antagonist for agitation, it might work a little bit quicker than giving them lithium, for instance, right, which takes a little more time. Or Depakote when you're not loading it. And I'm using outpatient as an example because you can't load Depakote or lithium obviously when you're outpatient. So if someone was like aggressive or not manic, because that's a psychiatric emergency, they would have to be hospitalized. But say they're hypomanic, and I'm wondering if they're dangerous to themselves and I have to get them out of the hypomania. Using an atypical antipsychotic would probably work faster than if I said, let's do lithium, do a level, and increase it accordingly, right? I can give them a decent dose of olanzapine and probably get them out of that hypomania a little bit quicker, right? So that's one of the advantages of using an atypical antipsychotic to a mood stabilizer, right? That answers the question that you guys, that was on the weekly, right? One of the goals, understanding the differences. The advantages of using a mood stabilizer in general compared to an atypical is that there's less metabolic issues, right? Depakote can cause weight gain, right? But not as much as giving them olanzapine, right? So if I was to compare weight gain with olanzapine and weight gain with Depakote, olanzapine has way more metabolic issues than Depakote, all right? Quetiapine, another med that can cause a lot of weight gain. What's significant about quetiapine, if you look at this, it's a broad spectrum mood stabilizer, all right? It works for bipolar mania, it works for bipolar depression, and it's also approved for maintenance. Another fun fact, quetiapine and cariprazine is the only 2 medications that have been FDA approved for bipolar depression type 2. Remember, we have 2 types. We have bipolar mania, bipolar depression is maintenance. If you look at this FDA approved, this is actually only for bipolar 1. Bipolar 2 is different. We only have 2 medications that are FDA approved for bipolar 2. Quetiapine and cariprazine, Vraylar. Okay. Quetiapine is broad spectrum, so if you weren't sure, that's why you see quetiapine prescribed a lot, right? A lot of prescribers use it because it's broad spectrum. It covers all the parts. The only problem with quetiapine, sedation and metabolic issues, similar to olanzapine, right? And plus quetiapine has something called a fast on, fast off Ki value or affinity. You know what that means? What does that mean? A fast on, fast off Ki affinity value. It goes on and off the receptor very quickly, all right? It goes on, then it goes off. It goes on, it goes off. So it goes on dopamine receptor, dopamine goes on. It goes off, dopamine goes off. Goes on, it goes off. Goes on, it goes off. Goes on. And they kind of keep going on and off. The importance about that, the reason why that's significant is quetiapine has it's one of the meds together with clozapine that doesn't really cause EPS. I've only seen EPS with quetiapine a handful of times. And most likely it probably wasn't from the quetiapine. It might have been residual from the other antipsychotic meds the patient was on. It's because of the fast on, fast off affinity. It also makes sense that the affinity is not that strong because have you ever seen the doses of quetiapine with patients with mood disorders? What's the highest quetiapine dose you guys have seen? Any psych nurses here? What's the highest? I'm curious. Have you seen 1,000 milligrams? 800 milligrams?
I seen
100.
800.
Yeah,
800.
it's high, right? Yeah. Why do you think it's high? The reason why the dosage is so high is because of the affinity, right? The affinity is not that strong that in order to target that D2 receptor, you need to give them a much higher dose, right? In order for me to say, I want to block 80% of your D2 receptors per cycle, which is why it's a very poor antipsychotic medication. This conversation is not for schizophrenia, it's for bipolar disorder. So D2 receptor blockade is not as important. But in schizophrenia, if you tell a patient, I'll give you 20 milligrams of olanzapine to block your D2 receptors, or I can give you 800 milligrams of quetiapine, it's equivalent. Patient's going to say, no, give me 20 milligrams of olanzapine, right? Because of the binding affinity is much different. Quetiapine's binding affinity for D2 is so low, and the fast on, fast off, to get that same equivalent of blockade, you need to give them a much higher dose of quetiapine, which is not even practical, right? It's like swallowing 4 pills of 200 milligrams, right? Their throat's gonna hurt them. So quetiapine, metabolic issues. Make sure you check fasting blood glucose, right? Make sure you check lipids, triglycerides. Make sure you do A1C also, right? Make sure you counsel them. Make sure you check for waist circumference, right? Because remember, it's metabolic syndrome. You want to check for the waist circumference. You want to check their blood pressure. You want to check their fasting blood glucose. You want to check their triglycerides. And if they meet a certain amount of criteria, they have metabolic syndrome, right? Which you want to prevent in patients. We're going to talk more about metabolic syndrome when we get to schizophrenia psychosis, right? Ziprasidone. The thing about ziprasidone you should know is that it causes the least, one of the least amount of metabolic issues than a lot of the meds, right? Latuda and ziprasidone are about equal when it comes to a risk of metabolic issues. The only problem with ziprasidone is it can cause QTc prolongation. So, make sure that you do an EKG in a patient that's on ziprasidone, okay? Or if there are other meds that can prolong QTc as well, like SSRIs, tricyclics, right? Make sure that you check EKG, okay? Questions? I'm just touching the important parts to know about the medications, okay? Aripiprazole, D2 partial agonist, right? There's 3 of them that are D2 partial agonists. I mentioned them during our first lecture. You have aripiprazole, you have brexpiprazole, and you have cariprazine, Vraylar, right? Aripiprazole is the most agonistic of that. So even though it's a partial agonist, it gives a little bit more dopamine than the other ones do. Sometimes that can be too stimulating. So there are case reports of people on low dose aripiprazole who actually can become manic, right? Interesting, right? It's FDA approved for bipolar mania. So if you're going to give aripiprazole for bipolar mania, make sure you give a pretty decent dose. I would give at least 5 milligrams. Don't do 2 milligrams. 2 milligrams is an adjunct for depression, MDD depression, right? If you're trying to treat bipolar mania, start with 5. Unless the patient is on an inhibitor, then you would give them low, obviously, right? Does that make sense? It's a partial agonist. The most common side effect I see with aripiprazole is actually akathisia, all right? Akathisia means that they have an inner sense of restlessness, they're pacing around. If you see them in person, they're walking around, they can't sit still. Sometimes they might say it feels like they have ants crawling up and down their legs, right? And if they try to sit down, they just can't do it. They feel very uncomfortable, okay? Acenapine, there's really nothing significant about acenapine other than the fact that it comes in sublingual, all right? It comes in a sub. I've never used it, but I don't know what the advantage of using sublingual. Maybe it's faster. Yeah, I guess it doesn't go through first pass metabolism. It goes sublingually, goes right into your bloodstream. But that's the only really difference with acenapine compared to the other meds. It's still a D2 blocker. All right. Quick review: Depakote. Do not give in women who want to get pregnant or who are pregnant. Okay. If they are on it, make sure you supplement folic acid because it can deplete folate levels. Okay. Make sure that you check liver enzymes and you check for any nausea, vomiting, or stomach pain because you want to make sure they don't have pancreatitis. Okay. Lithium. Make sure that you check renal functioning before you start the medication. Make sure you check TSH. Make sure you check CBC because they can elevate white blood cell count. Okay. Make sure they don't have something called sick sinus syndrome because that's contraindicated. And make sure they don't have any skin issues because it can worsen skin issues. All right. Lamotrigine. Stevens-Johnson syndrome. Make sure that you titrate it accordingly, right? There's a titration table that you guys should use that you can find. It's usually 25 milligrams for 2 weeks, 50 milligrams for 2 weeks, 100 milligrams for a month. If you're giving lamotrigine to someone who's on Depakote, make sure you cut it in half, right? Because the Depakote can slow down lamotrigine metabolism through the UGT system or phase 2 metabolism. Okay. Carbamazepine, very strong inducer. So make sure that if someone's a carbamazepine, you adjust the medicines, the other meds are on accordingly, okay? And also you recheck carbamazepine levels because it induces its own metabolism, okay? Going back to valproic acid, make sure that you check albumin levels also if you're not sure if they're getting adequate nutrition, okay? Olanzapine, make sure you screen for metabolic issues and you explain to the patient that, you should probably try to live a healthy lifestyle because this medication is a great med, but it can cause weight gain, sedation, right? Risperidone, we talked about that last time, but remember, elevated prolactin, particularly with risperidone for whatever reason, all right? Actually, I know why. Risperidone is a very good substrate of the P-glycoprotein. P-glycoprotein is an efflux transport that pulls the medication out of your brain. The reason why that's important because when it pulls the medication out of your brain, it leaks into the tuberoinfundibular area, right? When it leaks into there, it increases prolactin a lot. So the risk of hyperprolactinemia is much higher with risperidone. And of course, it's active metabolite 9-hydroxyrisperidone or Invega, paliperidone. Make sure you do prolactin levels, okay? Thiopine, metabolic issues, sedation, broad spectrum. So it covers all of the parts of bipolar disorder. You can do depression, bipolar mania, maintenance, right? It's also the only FDA-approved medication for bipolar 2, right? Bipolar type 2. Ziprasidone, make sure you do EKGs, especially if they're on their medication that have QTC prolongation effects, okay? If they have if their QTC is fine and they have no EKG issues, ziprasidone might be a good medication for patients who don't want to gain any weight, right? It's almost metabolically neutral, similar to Latuda, lorazepam. Aripiprazole, D2 partial agonist, okay, causes akathisia. Make sure that that you check them for akathisia, right? It's indicated for mania and for maintenance only, not bipolar depression. The confusing thing about aripiprazole is you do see it added for depression, right? But it's MDD adjunct for major depressive disorder as an adjunct, not for bipolar depression, okay? It's been studied in bipolar depression and it's failed numerous times. Acenapine. It's a second-generation antipsychotic, but it comes in sublingual form, okay? That's the only thing about it. Mechanism of stabilize, we talked about this last time, but just know that, Depakote works on sodium channels, and that's why it's an anticonvulsant. It also enhances GABA. That's why it's effective for mania, all right? Carbamazepine, similar. Make sure you check for HLA-B1502. If anyone you're going to start on carbamazepine who is of Asian ancestry, okay? Because their risk of Stevens-Johnson is much higher. Some people recommend to do it for starting lamotrigine as well, but that hasn't been validated yet. So that's not part of the guideline. So it's not you could do it, but it's not recommended. Okay. Lamotrigine, make sure you teach about Stevens-Johnson syndrome. Okay. Check for a rash, any systemic symptoms, fatigue, fever, where the rash is, if it's on their face, on the oral mucosa, there's higher risk that it's actually Stevens-Johnson. Okay. All right. That's a lot. Questions? Confusing? All right. So remember, yes, Alec, question.
Sorry, Professor. For the test, I know that you said that everything is fair game, but anything about doses or levels in particular, or that we need to know, or I know
dosing level, particularly for Depakote and lithium and carbamazepine, you need to know that. I'm not going to ask you about levels for the other meds, like any antipsychotic meds, but you should know the levels for lithium. Not really the dosing, but the levels are more important. Because dosing, you're going to base dosing off of levels. So you should know, like I said, half a dozen to a dozen. It's just a guidepost. 0.6 to 1.2 would be, on average, a normal lithium level, right? That's therapeutic. For Depakote, 60 to 120. For carbamazepine, 6 to 12. Okay?
Okay. Thank you.
Those are 3 levels you should definitely know. And know that, Depakote is toxic to the fetus or women of childbearing age. And lithium can cause issues for the kidneys, and that Depakote can cause issues for the liver. And carbamazepine can cause hyponatremia, and you should do HLA-B1502 with patients of Asian ancestry.
Professor, I just had a quick question.
What's the question?
I was looking at the Flockhart table for the CYP enzymes, the substrates, inhibitors, and inducers. It's quite a bit. Are we expected to essentially just focus on like the drugs that were essentially covered, in the lectures, or?
Yes, I'm gonna tell you the important interactions you should know. Okay, bupropion, which is DNRI, fluoxetine, and paroxetine. All right, those are very strong 2D6 inhibitors, or very strong inhibitors, not just 2D6, because some of them inhibit 3A4. BFG, big effing paroxetine. All right, now you don't forget it. Okay, bupropion, fluoxetine, paroxetine. If you don't adjust the other meds, you're gonna get into big effing paroxetine. Okay.
Gotcha. Thank you.
Those are very strong inhibitors. Bupropion, fluoxetine, paroxetine.
Big effing problems.
Very good. Know to distinguish bipolar depression from regular depression, and that's because they have an episode of mania or hypomania, right? A manic episode are those symptoms that occur for at least a week period, okay? One fun week. Hypomania, they say it's a little bit less severe, but I disagree with that because it can be just as impairing as a full manic episode, but it's just less. The duration is 4 days minimum, okay?
I do have a question about the anxiety topic that we have to do. I know we didn't go over it, but do you know what exactly we should focus on for that, since we're not going to have like a review prior to the exam?
A lot of the meds that so a lot of the MDD treatments are very similar to, just to touch on that topic. Serotonin, norepinephrine also modulate the anxiety pathway. So you just know that by increasing serotonin, norepinephrine, it also can have an anti-anxiety effect. Okay, which is why they're used for the same, right? Someone has general anxiety, so we use an SSRI. If someone has MDD, we use an SSRI because they can. Believe it or not, people call SSRIs antidepressants, but their effect size is actually much higher for anxiety than it is for depression. The effect size, I believe, is like 0.3 for depression. For anxiety, it's like 0.5, 0.6, which is a moderate effect size. It's a low effect size for depression. All right. Just so you know, anything that has an effect size of like 0.1 to 1.3 is considered a low effect size. Anything that has an effect size from 0.3 to 0.6 is considered moderate. Anything above that is considered a significant effect size. Let's say, for instance, stimulants. The effect size is like 1 or higher. Because once you take a stimulant, you feel it right away, right? It's a very strong effect. And the effect size is calculated based on placebo. Also, obviously, for anxiety, benzodiazepines, increasing GABA can help with anxiety. Okay. But make sure that you educate them on the fact that it could be, addictive and it has dependency and tolerability issue, tolerance and dependence issues if they stay on it for too long, or they're using it not the way it was prescribed. They're not combining it with alcohol. So this is a psychopharmacology class. When we talk about anxiety and psychosis on Friday, a lot of it's going to be repeated again, because again, the mechanisms are still going to be the same. Notice when I was talking about mania, I was talking about psychosis at the same time, right? Because technically, mania and psychosis is still a hyperactive dopamine state. So if you understand the mechanism of the meds, you should have no problem just making sense of that and understanding you can give someone a D2 blocker, all right? But the thing is, for whatever reason, a Depakote works for mania, right? But it doesn't work for psychosis. But that's the only exception. Like lithium doesn't work for psychosis, but it works for mania.
We're gonna have the I guess the class, and then we will probably more likely than not take the test afterwards, I guess, just to make sure we have everything.
You want to, yeah.
Professor,
Yes.
can you explain the addiction pathway, like why like benzodiazepines would be addictive compared to like an SSRI? They both downregulate the receptor, right?
Yeah, there's a section for we're gonna talk about actually substance use disorders, one of the sections, but in general, GABA can also cause a euphoric effect, right? So it's when you stimulate the GABA neurons, after a while, what's gonna happen is it's gonna downregulate, right? So when it downregulates, you need higher dose of the meds, and when you keep getting a higher dose, it's gonna cause a euphoric effect again. And then what's gonna happen? Your brain's gonna downregulate again. You have to increase the dose to get the euphoric effect again. Then you're gonna hit the point in which you're chasing that euphoric effect, but at the same time, that same dose that gives you euphoria can also cause respiratory depression, right? So then you hit respiratory depression, and then before you can feel good, you're already dead, right? That's what happens. Especially when combined with other, like when the dangerous combination, GABA with opioids, very dangerous. Especially Xanax with Suboxone or methadone or something. Yeah. Even though we see it, shouldn't be prescribed unless really indicated. Like I said, once you guys are practicing, you're kind of free to do what you want. And the sad part is, once you're out there, you're going to see a lot of the stuff you learned in school, a lot of people throw out the window, right? Why are all these doctors, NPs prescribing? And they're not doing the right thing, actually. You know, the reason why I came back here to teach is because I want to make sure that I train you guys to do it appropriately and that, you know, you guys can represent this well, right? All the other future nurse practitioners, because you guys are going to be part of a small group of people, right? That are going to be providing mental health care to a large amount of people. There's actually a statistic now. There's so many psychiatrists that are leaving the field and not enough getting into residencies that PMHNPs have eclipsed them so many times. So there's a good chance that PMHNPs are going to take that role of being the primary care mental health providers. And psychiatrists might just, you know, treat more specific, you know, cases or more, you know, treatment resistant, quote unquote. Not saying you can't do that either, but it looks like it's going that way. That's the trend. So make sure you guys are trained appropriately and you guys know what you're doing is my job.
I just want to clarify what you explained. So the SSRIs, because they don't cause that euphoric feeling, then you're not like, you don't like chase that feeling and it doesn't become addictive?
Yes, and I'll tell you why. I don't want to confuse everyone, but remember, serotonin binds to a receptor on a dopamine neuron called the 5-HT2A receptor, right? Dopamine makes you feel good. So technically, by increasing serotonin and binding to the 5-HT2A receptor, it kind of makes you feel flat. That's why some people sometimes on SSRIs, they get something called apathy syndrome, SSRI-induced apathy syndrome. They kind of feel, I'm not depressed anymore, but I'm not happy either. I just kind of feel, I feel flat. That's because you're increasing serotonin so much that it's binding to that 5-HT2A autoreceptor, which is actually bringing down dopamine, which is in contradiction to olanzapine, which is a 5-HT2A antagonist, right? Which increases dopamine, right? If you stimulate the 5-HT2A receptor, you're gonna drop dopamine, apathy. If you block the 5-HT2A receptor, you can actually increase dopamine, right? Does it make sense now? A little bit?
Yeah.
I just wanted to ask a question.
Sure.
So they have drugs that inhibit like they're partial agonists, like the Spari, and I was just trying to understand it, but I was getting a little bit lost.
Okay.
You know, like down regulates, but it was like a little confusing.
So Aspari is a medication that's a serotonin partial agonist, and usually it's a partial agonist at the 5-HT1A autoreceptor. So technically, Aspari is like you giving someone an SSRI and buspirone at the same time. All right. There was a medication in the market called vilazodone, Vibrate, back in the day. It's still out, actually. It made generic, and the company never made that much money off of it. And the reason why is because people were like, "Why am I gonna do pre-authorizations for a medication?" You know, and go through the hassle of I could just give them Buspar and an SSRI, same mechanism, right? Give them Buspar, 5-HT1A partial agonist, and you give them a serotonin reuptake inhibitor. So technically, Aspari stands for SP, stands for serotonin partial agonist, right? SPA, and RI stands for reuptake inhibitor. So any medication that is a reuptake inhibitor and also a 5-HT1A partial agonist, right? Vilazodone is one. Okay, another Spari, I believe, is trazodone. It's a 5-HT1A partial agonist, and at high enough doses, it's also a reuptake inhibitor, right? So just do you guys know 5-HT2A and 5-HT1A are like yin and yang, all right? I'm going to say it slowly so you guys can understand it. 5-HT1A, when you stimulate it or give a partial agonist, is a dopamine accelerator. Think of a car. You're pushing down the acceleration, so it increases dopamine. 5-HT2A is actually a dopamine brake. So when you stimulate 5-HT2A, it's going to what? It's going to bring dopamine down, right? That's how the brain works. You always have to have something that's going to increase something and decrease something because you need a safety net, right? So if you give someone 5-HT1A partial agonist, right? In a way, it's almost like you're giving them a 5-HT2A antagonist, right? Think of that again, because they said they're yin and yang. They do the opposite of each other. I'm giving someone a 5-HT1A agonist or partial agonist. It's the same as me giving them a 5-HT2A antagonist. It's still going to increase dopamine, right? That's why it helps with side effects. That's why if you give someone a partial agonist, the argument is it can increase dopamine because you're stimulating that 5-HT1A receptor, increasing dopamine, and there's less sexual side effects. Does it make sense? I can do the same thing by giving them a 5-HT2A antagonist also. You give them, you know, besides, well, I like to use trazodone because it's both. It's a 5-HT1A partial agonist, also a 5-HT2A antagonist, right? I can't think offhand what's just a specific 5-HT2A antagonist by itself, but if you were to give someone a 5-HT2A antagonist, it will mitigate, just by itself, it will mitigate sexual side effects also, because it'll increase dopamine.
Sorry, Professor, just to clarify.
Oh, Ali can't hear you. Ali, say it again. I can't hear you. You're cutting off.
Can you hear me now?
Yes.
Can you hear me now?
Yes.
Okay. So 5-HT1A agonist increases dopamine, and then 5
Elliot, I can't hear you, but I'm going to repeat what I think you're saying. But I'm going to say a 5-HT1A partial agonist will increase dopamine, right? And a 5-HT2A antagonist will increase dopamine, right? Because they're reciprocal of each other. They're yin and yang. They're there to protect the neuron. If there's too much 5-HT2A, then the 1A has to work, right? So you need to drive a car that has acceleration and a brake at the same time. You need a brake and you need an accelerator, right? To balance things out. Does that answer your question, Elliot? Sorry, I can't hear. I think your connection is low. Any other questions? The beauty of understanding the mechanisms of how the meds work, instead of just memorizing the meds, like, I don't know, Haldol, schizophrenia, Abilify, schizophrenia, bipolar mania, right? Is that you can kind of look at the mechanisms, and not that you're creating meds, obviously, but you can kind of make your own combinations of meds targeting specific symptoms of the patients, right? So if a patient comes to me and says, I have low motivation, I don't want to have sexual dysfunction, I don't want to gain weight, I'm going to increase dopamine, right? Because by increasing dopamine, it suppresses appetite, increases focus. As long as the person doesn't have a family history of psychosis or addiction, it's a fairly safe treatment, right? If a patient says, I'm having more issues with energy getting out of bed, that's a norepinephrine issue, right? So I might need to increase norepinephrine there. Someone says I have suicidal thoughts and I just have feelings of unwellness, feeling low, guilt, right? I also have anxiety. Good. That's a serotonin pathway, right? Maybe I want to increase serotonin in that way. Now, when someone is getting those treatments and they come to you and they say, the last doctor I was with or NPO was with gave me this medication and now, I'm having sexual side effect. In your mind, you say, okay, you're taking an SSRI. That's because it's innervating the 5-HT2A receptor, which is dropping dopamine. So it's killing your sex drive and killing your ability to perform, right? So I'm going to give you Prazidone. It's a 5-HT2A antagonist to counteract that. Or I'm going to give you Wellbutrin to increase the dopamine that way, so that it'll increase the dopamine where dopamine is not enough, right? Does it make sense a little bit? Instead of memorizing names of the med, I know it's a 6-week course, so you might have no choice, but try at this early on in your career now to try to make an effort to understand the mechanisms. It'll make things a lot easier as you progress. And it'll make sense why you're prescribing a certain med, right? I might say, let's say you're doing clinicals with me in a year from now. And I say, what are you doing, Elliot? Why are you prescribing a medication that's going to increase dopamine? Don't you know that patient has a mom that's schizophrenic and the dad has issues with substance abuse, right? And it should make sense. Yes, you're right. I don't want to increase dopamine that much because I might excite the reward pathway and put this person on a path of addiction or make them psychotic, right? Let me use other ways to increase dopamine indirectly. Maybe I'll increase dopamine using norepinephrine pathway, right? I'll increase dopamine by giving them atomoxetine. And our norepinephrine reuptake inhibitor will increase dopamine inadvertently in the frontal lobe, increase focus, but not increase dopamine in the mesolimbic area and worsen psychosis or cause addiction, right? The only way you'll know these ways, if you understand the pathways, know where in the brain these receptors are, and where in the brain some of the medicines work, right? That's why you're going to get paid the big bucks once you guys are practicing. You have to know this stuff. No excuses. Any other questions? I have to get off in a few minutes, so ask now.
So this Friday it's at 11 o'clock, right? For the anxiety
Yeah, we're
portion.
going to talk about anxiety. Yes, anxiety and psychosis.
Okay.
And I'm going to review the same stuff again. If I were you guys, I would focus on understanding what D2 antagonism does, what 5-HT2A does, and what the receptors do, and what symptoms they can cause and what they don't do. Because you can easily put that in the treatments, right? Because if you know what D2 antagonism does, right, helps with aggression, helps with psychosis, helps with mania, right? You can kind of deduce that if it helps with mania, it should help with psychosis, right? If it helps with anxiety, if it helps with depression, and serotonin is also involved with anxiety, it should work for those at the same time, right? Right. Well, thank you very much, everyone, for coming on a Saturday morning or Saturday afternoon. Okay. If you have any other questions, shoot me an email. Like I said, once again, the final, I'm going to put an announcement after this so everyone in the class who wasn't here sees it. The final is going to be cumulative. And remember, the midterm is going to be all 3 sections. So anxiety and psychosis will be on there as well. Okay. And I'm going to take a look at the questions to make sure that it's fair for what I taught you guys. But you also need to read those also because there's so much to cover that there will be a few questions on there that I didn't have a chance to cover that are important that if you didn't do the readings, you're going to miss. Okay.
Thank you.
Okay. Take care. Have a nice week.
Thank you.